Acid-base imbalances. We're going to talk a little bit about an overview of the acid-base physiology before we get started looking at evaluating arterial blood gases. First, the nature of acids and bases. An acid is a substance that releases hydrogen ions when dissolved in water. A base is a substance that will bind to the hydrogen ion when it's dissolved in water. Now, our body has chemical buffer systems. Buffer systems prevent major changes in the ECF by releasing and accepting hydrogen ions. That makes those hydrogen ions very important when we're talking about acid-base balance. The major chemical buffers that are found in the blood include the carbonic acid bicarbonate buffer system, the phosphate buffer system, and the protein buffer system. We also have physiological buffer systems in our body. One is the pulmonary regulation. The pulmonary regulation is when the lungs control the respiratory carbonic acid buffer system. The lungs compensate for acid-base disturbances that are primarily metabolic in nature. So whenever you have a metabolic abnormality, your lungs are going to compensate. So lactic acidosis that occurs with exercise. That's just an example. You're going to blow off that carbon dioxide. In an acid environment, respirations increase to blow off the CO2. In an alkaline environment, respirations slow down so that you retain the CO2 that you need. The respiratory system is extremely sensitive to changes in pH and will begin compensating within seconds to minutes. These mechanisms come on very quickly, but they can also be quickly exhausted. This system is not as efficient as your renal compensatory systems. Also, it's good to know that the elderly have a reduced amount of gas exchange during breathing, which makes CO2 retention and increased hydrogen ions a problem for them. We also have a renal regulation. The kidneys control the metabolic buffer sodium bicarbonate by excreting an acidic urine or an alkaline urine. This system works within several hours to days, so it's much slower to start working, but it's very powerful and it can eliminate either acids or bases when it's needed. Kidneys control the bicarbonate in the ECF by either reabsorbing or excreting the hydrogen ions. They can reabsorb bicarbonate as needed, or they can secrete free hydrogen into the renal tubules. The kidneys can also combine ammonia with hydrochloric acid to form ammonium, which is excreted by the kidneys, and approximately 50% of excess hydrogen can be excreted this way. Now, renal function decreases with age, so elderly clients don't excrete hydrogen ions and synthesize bicarbonate as efficiently. That's why acid-base imbalances are more difficult to correct in the elderly, especially when they're suffering from other conditions like pneumonia, fever, or infection. The next thing we're going to talk about, and you're going to understand more of this later, is compensation. Now, compensation for an acid-base imbalance occurs when your body uses those regulatory mechanisms that we talked about to return the pH to normal. Now, the pH is normal, but then there are other abnormal amounts of CO2 and of bicarbonate. Now, a primary metabolic disturbance will be corrected with respiratory compensation. A primary respiratory disturbance will be corrected by a metabolic response with the buffering system. So your kidneys will compensate for a respiratory disturbance. Lungs will compensate for a metabolic disturbance. Complete compensation means that the buffers have achieved a normal pH and the pH is fully corrected. If you have a partial compensation, which you'll hear us talk about, it means that the buffers are in the process of working to restore a homeostasis. Correction of an acid-base imbalance occurs when lungs and kidneys eliminate the offending substance from the body, so whether it's the CO2 or the bicarbonate levels. When you're evaluating arterial blood gases, you're always going to evaluate the PaO2 first. The PaO2 is the easiest to fix. A normal PaO2 is 80 to 100. If it's less than 80, we need to add oxygen. Always evaluate if oxygen is necessary. If it's greater than 100, then we need to remove the oxygen. Anyone over the age of 65, you're going to want to subtract 1 for each year until 75 when the abnormal ABGs of the PaO2, when the normal ABGs PaO2 would be 70 to 100. So if they're 66, 79 to 100 would be normal. From the age of 75 on, 70 to 100 is normal. After reviewing the PaO2, you'll go to evaluate the pH. So you determine if it's an acid or a base. And then you determine if the CO2 or the bicarbonate, the HCO3, is the same as the pH. Evaluate the CO2. The lungs are again easier to fix. It starts working within seconds to minutes. And you'll evaluate if it's an acid or a base. Then we're going to evaluate the bicarbonate, and you're going to decide if it's an acid or a base. One of the ways that people remember to use as a memory device to remember acid-base imbalances is called Rome. If you look on page 324 of Lewis, you'll see in table 1717 the Rome memory device. For acid-base imbalances, how some people remember is in respiratory conditions, the pH and the PaCO2 go in the opposite direction. So in respiratory alkalosis, the pH is elevated, so we know that the alkalotic, and the PaCO2 is decreased. And in respiratory acidosis, the pH is low, but the PaCO2 is elevated. See how in respiratory it's the opposite. Metabolic, they're equivalent, so that's where we get our ROME. So in Rome, in metabolic conditions, the pH and the bicarbonate go in the same direction. In metabolic alkalosis, the pH and the bicarbonate are both elevated, and the PaCO2 is elevated or normal. Metabolic acidosis, the pH and bicarbonate are both decreased, and the PaCO2 is also decreased or normal. So a normal pH is 7.35 to 7.45. If it's acidotic, your pH is less than 7.35. If it's alkalotic, your pH is 7.45. Now, your ideal pH is 7.4. So if you are nearing the lower end of normal or the upper end of normal, then you know that your patient may be becoming either acidotic or alkalotic. Hydrogen ion concentration. The acidity and alkalinity of a solution depends on its hydrogen ion concentration. For in acidosis, whenever the pH is going down, the number of hydrogen ions are going up. That is what makes them acidotic. Alkalosis, if the pH is going up, it's because the hydrogen ions are going down. One way some people will remember this is that with the PCO2, if you put a 7 in front of the 35 to 45, so if you put it in 7.35, 7.45, the pH runs the same as the PCO2. Now we're going to talk again. Remember, we talked about compensatory systems. We have two regulation systems. For the lungs, it regulates the PCO2 or the carbonic acid. Kidneys regulate the bicarbonate, the HCO3. So our normal values for PCO2, the carbonic acid, are 35 to 45. It's acidotic if it's above 45, and it's alkalotic if it's below 35. HCO3, the normal is 22 to 26, considered acidotic if it's less than 22, or more, or alkalotic if it's more than 26. In other words, you'll hear us talk about acid and base. So this is what we're talking about. If the PCO2 is more than 45, we're going to call that an acid. If it's less than 35, it's a base. Respiratory imbalances. The lungs regulate the PCO2. So the two imbalances that we'll experience with our respiratory system are respiratory acidosis or respiratory alkalosis. These are the only two that will never occur together at the same time. The reason is you cannot hyperventilate and hypoventilate at the same time. So try to remember that. Respiratory acidosis and respiratory alkalosis will not occur at the same time. Other acid-base imbalances can occur at the same time. Now the metabolic imbalances, the kidneys regulate your HCO3, which is your bicarbonate, and we may have metabolic acidosis and metabolic alkalosis. In respiratory acidosis, our lab values are going to look like this. Less than 7.35 for the pH, which means it's acidotic. A PCO2 that's above 45, which tells us that it's respiratory, and an HCO3 is normal, 22 to 26. So it's uncompensated respiratory acidosis. Causes for respiratory acidosis: CO retention from hypoventilation. So respiratory acidosis will occur with hypoventilation. So our patients that will have hypoventilation are COPD, pneumonia, a chest wall injury. We can have neuromuscular abnormalities like MS, muscular dystrophy, or Guillain-Barré syndrome. Things that cause CNS depression that cause the hypoventilation will lead to CO2 retention. Mechanical ventilation, where we're hypoventilating. Pulmonary emboli, or cardiopulmonary arrest. Treatments for respiratory acidosis is we want to improve ventilation and decrease the PCO2. So what we can do is give bronchodilators, supplemental oxygen. These patients are going to have hyperkalemia, so we're going to give drug therapy to treat the hyperkalemia, analgesics to treat any infection, removal of foreign body from airway, or increased respiratory rate on ventilator. So all of these interventions, these interventions are geared at fixing the cause of the hypoventilation. Respiratory alkalosis. So with our respiratory alkalosis, we're going to have an elevated pH that tells us that it's a base, right? So alkalosis. PCO2 is decreased, so we know that it's respiratory related because our PCO2 is abnormal, and we have a normal HCO3. So our bicarbonate's normal, it's unchanged, we know it's uncompensated. That buffering system has not started working. Respiratory alkalosis is when there's excess CO2 excretion from hyperventilation. So our patients that can be in respiratory alkalosis are patients with anxiety or fear, so panic attacks, patients in pain, exercising. A pulmonary emboli can also cause a respiratory alkalosis if our patient's hyperventilating. Pneumothorax or hypoxia. Patients with elevated temperatures, so they have fevers, septicemia, salicylate poisoning, a brain injury, mechanical hyperventilation, or a hepatic coma are all patients that commonly suffer from respiratory alkalosis. Our treatment, again, is to fix the problem. So we're going to decrease the respiratory rate and increase the CO2. We're going to treat the underlying cause. So if it's a salicylate overdose, we want to reduce. So we're going to treat the salicylate overdose, we're going to reduce the fever, give antibiotics for sepsis. We do want to administer oxygen therapy for hypoxia. If they're having anxiety issues, they may need you to talk them through it to slow down their breathing. And decrease the rate of mechanical ventilation if they're on a ventilator. Metabolic acidosis. So we know that it's acidosis because we have a pH that's less than 7.35. We have a bicarbonate that's less than 22. And we have a PCO2 that's normal, 35 to 45, we know it's uncompensated. Causes of metabolic acidosis are increased metabolic acids. So we have production of keto acids. These are our diabetic ketoacidosis patients associated with diabetes. Starvation. So these can be patients that have ketones in their urine from starvation. Production of lactic acid when tissues are forced to metabolize carbohydrates without sufficient oxygen, so severe exercise or patients who are in shock. Failure to excrete organic acids or conserved bicarbonate, so severe dehydration. Renal failure or renal tubular acidosis. Increased loss of bicarbonate, so through diarrhea, a gastrointestinal fistula, or pancreatic drainage. Treatment for metabolic acidosis will also be geared towards the cause. So diabetics, we're going to administer insulin. We're going to support their airway and ventilation. We are going to need to monitor their potassium levels. A pH of less than 7.1, we're going to administer sodium bicarbonate. We'll give dialysis for renal failure. We're going to want to stop the diarrhea because if they continue to have diarrhea, they'll continue to become more acidotic. Metabolic alkalosis. This is when our pH is above 7.45, so we know it's alkalotic. HCO3 is above 26, so we know it's metabolic. PCO2 is normal, so we know it's uncompensated, 35 to 45. This is the most difficult acid-base imbalance to correct. This can be caused by a bicarbonate gain. So these are patients that are using sodium bicarbonate or baking soda as an antacid. A sudden decrease in extracellular fluid in which the kidneys reabsorb sodium and bicarb. These will be patients that are taking diuretics, steroid therapy, Cushing's or aldosteronism. Hypokalemia, especially from diuretics, prolonged NG suctioning, vomiting, Cushing's syndrome. This is because of the retention of the sodium and chloride and the loss of potassium and hydrogen. Drugs containing sodium bicarb, which are corticosteroids and antacids. Excess hydrogen loss is from vomiting or GI suctioning, severe vomiting. A deficit of potassium. So hydrogen goes out of the cell when potassium goes into the cell. This causes less hydrogen in extracellular fluids, which makes it less acidic. The treatment for metabolic alkalosis is going to be geared at discontinuing the diuretics, discontinue NG suctioning, treat the underlying nausea and vomiting. We can give Diamox, which will increase the renal secretion of the bicarbonate. Now we're going to talk about partial compensation. Here we're going to look at the pH and determine if the imbalance is an acid or a base. Then we're going to look at the CO2 and determine if that's acid or base, and the bicarbonate. Whichever is the same as the pH, then that is the underlying imbalance. And we'll give you some examples of that. If the underlying imbalance is respiratory, then the kidneys are compensating, which again will take at least 24 hours. If the underlying imbalance is metabolic, then the lungs are compensating. Now, for a partially compensated respiratory acidosis, we'll have a pH that's less than 7.35, which means we know it's acidosis. We have a CO2 that's more than 45, which means that's an acid. A bicarbonate that's higher than 26, this is the base. This is our compensatory mechanism. Our kidneys are retaining bicarbonate, and we're going to have acidotic urine. So we have a patient who has a partially compensated respiratory acidosis. Now with this patient, we can see, we know that the kidneys retain bicarbonate to get rid of the acid, but you can tell it's been at least 24 hours because the kidneys take that long to start compensating. Partially compensated respiratory alkalosis. So we know that a pH above 7.45 means that it's a base, so alkalotic. A PCO2 less than 35, we know that it's a base. Bicarbonate less than 26 is acid. This is our compensatory mechanism. Our kidneys are secreting bicarbonate. Partially compensated metabolic acidosis. The pH is less than 7.35. It's an acid. PCO2 is less than 35. That's a base. That's the CO2 excretion by the lungs, and we'll see our patients with Kussmaul's respirations. The bicarbonate is less than 22, which is an acid. Because two of them are acids and only one is a base, we know that it's acidosis. Partially compensated metabolic alkalosis. Again, if we start with the pH above 7.45, it's base. PCO2 over 45, it's an acid, so our lungs are retaining CO2 because we need it. Bicarbonate is above 26 and it's a base. That means we are in metabolic alkalosis because, again, two of those levels are a base and only one is an acid. Full compensation. To evaluate if our patient has had full compensation, first we're going to look at the pH, which will be normal. Now we're going to decide, is our pH on an acidotic side or the alkalotic side, with 7.4 being our normal. So if our pH is 7.35, 7.36, we're on the acidic side. If it's 7.43, 7.45, it's still normal, but that's on the alkalotic side. Next, we're going to look at the CO2 and decide if it's an acid or a base. And then look at the bicarbonate and decide if it's an acid or a base. We're going to determine which is the same as the pH. Fully compensated respiratory acidosis. We have a pH which is normal but towards the acidic side, so we're going to say it's 7.35 to 7.39. Our PCO2 is above 45, so that's acidotic, and our HCO3 is above 26, which is alkalotic, and that is to compensate. Our kidneys are conserving hydrogen ions. Now we know that it's acidotic because, again, two of our levels are on the acidotic side. Fully compensated respiratory alkalosis, our pH is 7.41 to 7.45, so we are on the alkalotic side. Our PCO2 is less than 35, so we're alkalotic or on the base side. Our HCO3 is less than 22. We have now become the bicarbonate's acidotic, and this is to compensate. The kidneys are secreting bicarbonate. Because two of our levels are on the alkalotic side, we're going to call this fully compensated respiratory alkalosis. Fully compensated metabolic acidosis. Our pH is 7.35 to 7.39. Normal range, acidotic side. Our PCO2 is less than 35, so our CO2 excretion by the lungs, this is alkalotic. Our HCO3 is less than 22, this is acidotic. We now have two levels that are on the acidotic side, which means that it's acidosis and it's metabolic. Fully compensated metabolic alkalosis, we have a pH 7.41 to 7.45, normal on the alkalotic side. PCO2 is above 45, so our CO2 is being retained by our lungs. It's acidotic. HCO3 is more than 26. It's alkalotic. Now we have two alkalotic or base levels. So we have a patient who's in metabolic alkalosis but is fully compensated. The way to really learn arterial blood gases is to practice. So during class we will be given time to practice evaluating ABGs.